This podcast is intended for educational purposes only and is not medical or legal advice. Always follow your local policies, procedures, and protocols when functioning in your respective profession. Additionally, the views expressed by the speakers and owners of this podcast are their own and do not represent the views of their respective employers. Listener discretion is advised.
Alert Medic 1 response.
Ken, Josh, and Mustafa here. Welcome back to the Alert Medic 1 podcast.
Hey guys, Mustafa here again with Alert Medic 1. We're going to be by ourselves with Dr. How do you say it? Stolbach?
Stolbach.
Stolbach. Oh, I got right on the first try. With Dr. Stolbach today. Really excited to talk to him about basically a toxicology 101 talk. Dr. Stolbach, you want to introduce yourself?
Yeah, so I'm Andrew Stolbach. I'm an emergency physician and a medical toxicologist at Johns Hopkins Hospital in Baltimore.
Wow. Okay. How did you get into well, I guess I should ask you first, how'd you get into medicine? And then I should ask you how you got into emergency medicine and medical toxicology too.
Yeah, so for medicine, I have an answer that's probably similar to a lot of folks. I liked science. I liked helping people. I liked working in teams, and medicine gave me all that. So, I found myself in medical school right out of college, and I've never looked back.
Yeah. Yeah. What about the toxicology stuff?
Yeah, so toxicology is a longer story. So when I was in medical school, I chose emergency medicine to do my residency, right? And, it kind of goes back to the things I said before. I like being part of a team. I liked helping people. And with emergency medicine, I liked the hands-on aspect of it. I liked seeing a lot of different kinds of pathophysiology. And then once I started my emergency medicine residency, I learned that there was a specialty called medical toxicology. And medical toxicology is the medical specialty. It's like I froze for a second.
Yeah, I think you did. It's all good. You last thing I heard was medical toxicology. You were about to explain it, and then you froze.
So medical toxicology is the medical specialty that deals with treating poisonings, overdoses, environmental exposures. Anytime a person meets something that's not a person and has an adverse effect. So it can be anything from common overdoses to snakes and spiders and stuff like that. But I found out about medical toxicology as a specialty when I was doing emergency medicine residency. And as it turns out, medical toxicology is really, in the U.S., it's a specialty of emergency medicine. That's one of the main ways to get into it, is from emergency medicine. And some of my great teachers in residency happen to be medical toxicologists. And so they just got me interested in the field. And then, I did a fellowship in it after residency and never looked back.
That's exactly what I was going to ask you next. What it was it a fellowship afterwards? So that's really interesting. So, yeah, let's jump into it. I mean, you kind of gave us a definition already, but if you were to, toxicology and toxins, if you were to give a basic answer, one word, or one sentence answer, how would you define toxicology?
So toxicology is the medical specialty that focuses on helping people who suffer from, poisoning, overdoses, or environmental exposures.
Huh. And I always thought about the saying, and it just came back to me again, of the dose makes the poison, right? Many things that are
a toxicologist.
Yeah. Yeah, because many of the drugs that we see and that we use in even in EMS in the pre-hospital setting, given if you give too much or if you give something too fast, it can have certainly deleterious consequences. So let's dive into toxidromes. Is that cool with you?
Yeah.
All right, so let's go into that.
So toxidrome is not a real word, but,
Oh man,
but
damn.
we say
Okay.
it all the time. I say it.
All right.
I think the correct word, or the correct term, is really toxic syndromes. But I'm just going to say toxidrome because everybody says it. But a toxidrome is a constellation of signs and symptoms that point to a specific overdose. And the cool thing about toxidromes is that these signs and symptoms that you can get from your physical examination. So you don't need lab tests, you don't need imaging. And the other really cool thing about toxidromes is that they point you to directly to management. And so, if somebody has a sympathomimetic toxidrome, it doesn't matter if they got there from cocaine or methamphetamine or MDMA, which can all cause that sympathomimetic toxidrome. It doesn't matter how they got there, but the management's always going to be the same. It's going to be the management of that sympathomimetic toxidrome. So the toxidrome approach is so cool because you just identify the toxidrome based on your physical exam, and then you go from there to your treatment.
Yeah. So, breaking it down a little further, they're working on similar sites of action, right? So, or have similar mechanisms of action, or any and all of those things, or
Yeah, similar mechanisms of action, right? So take a classic opioid toxidrome. So the opioid toxidrome can be caused by any opioid. So whether it's fentanyl or methadone or heroin or oxycodone, you may not be able to tell. You won't be able to tell. You won't be able to tell the difference from examining the patient. But they can all cause findings of the opioid toxidromes. They can all cause sedate mental status, low pulse, low heart rate, low blood pressure, low respiratory rate, of course, small pupils, decreased bowel sounds, cool skin, right? And so you can see that combination of findings. That's the opioid toxidrome, and you won't know whether it's fentanyl, methadone, oxycodone, some new nitazene opioid out there. You won't be able to tell the difference, but you'll know that the treatment is treatment of the opioid toxidrome, which is to support their breathing and try giving them naloxone and get them breathing.
Got it. I have a list of 5 toxidromes here. I don't know if there are. I'm sure there are others, but I have like the sympathomimetics, like you said, the anticholinergics, the cholinergics, sedative hypnotics, and opioids. Can you think of others? Or are those pretty much?
Yeah, depending on who you ask and what textbook you look at, there's others. So you can throw in 2 withdrawal syndromes in there. So you can throw in I don't know if you said opioid withdrawal instead of hypnotic withdrawal. Those go in there, and then you can sometimes people add serotonin toxicity, otherwise called serotonin syndrome.
Yep, and we did an episode on that. Go to the episode with Dr. Jim Brady if you guys want to listen to an episode just on serotonin syndrome.
Nice. Yeah. So there's. See, it all depends, I think. But the main ones, I think we've named all the main ones, all the cardinal
ones. Okay. So let's go into a little bit about what are your thoughts on the mechanisms briefly of each? We kind of already talked about sympathomimetics. Let's talk about cholinergics and anticholinergics.
Yeah. So the cholinergic toxidrome, really in the U.S., it may be one of the rarest to see it really, really bad, but it may be common in other parts of the world. So cholinergic toxidrome is something from toxins that increase the amount of acetylcholine at synapses in the autonomic nervous system and at the neuromuscular junction. So what are things like that? Those are things like your nerve agents, right? Like sarin and soman and tabin and VX, right? Those can do that. Also things like certain acetylcholinesterase inhibitor organophosphate pesticides, like having a mental block about thinking of the names of one of those right now, but there's a bunch of them. Yeah. So the cholinergic toxidrome then can present classically with some muscarinic findings that are very evident to the observer. Salivation, lacrimation, urination, defecation, emesis, some people call it sludge, right? M for meiosis. People also talk about the killer bees, the bradycardia and the bronchorrhea, it being really dangerous, aspects of muscarinic toxicity. But really probably the most lethal aspect is the muscarinic or the cholinesterase activity at the neuromuscular junction, the nicotinic receptors at the neuromuscular end plate. And that causes fasciculations and paralysis. So you literally can't breathe. And that's you generally on nerve agents can kill somebody from respiratory muscle paralysis. And so that's the cholinergic toxicity.
And when we talk about the duodotes and other treatments, how we're attacking those then is atropine is just counteracting the tons of whatchamacallit, now I'm having a brain fart. Acetylcholine, right?
Yeah. And atropine is a great antidote. And atropine will really only target those muscarinic receptors, that the sludge, right?
Mm-hmm.
The salivation, the lacrimation, the urination, the defecation. The most important thing is really the secretions. We give atropine and we titrate it to the drying of secretions. So we don't want people to be like, coughing and wheezing and having pulmonary edema. Okay. But the paralysis aspect of it, the neuromuscular junction weakness, the atropine actually doesn't address that.
Yeah. And so that's where I guess the pralidoxime would come in, correct?
Pralidoxime, yeah. And so that will help preserve acetylcholinesterase function, so that you still have nicotinic acetylcholine receptors working at the neuromuscular junction.
Okay. And then in severe cases, when there's seizure, that's when the benzos come in, correct? With like diazepam
That's
and such.
exactly right.
Okay.
Yeah. So benzos will treat seizures, and they'll treat CNS toxicity.
Okay. And so Dr. Stolbach said something that I think the listeners should really hone in on, and we're talking about the parasympathetic nervous system here of the autonomic nervous system. That feed and breed response is getting super upregulated with these cholinergics, and that sludgem is like a symptom of that. When we talk about the toxidromes, you mentioned like symptoms, right? So a cluster of symptoms that point us to something. Because certainly in the pre-hospital setting, we function all the time with limited information, and this may be, I can't help but think of the Novichok attacks in Britain. A few years ago, well, more than a few years ago now, which was a binary nerve agent, the targeted assassination attempt, which was a very strong nerve agent, which ended up, unfortunately, killing at least one person, I believe. And those were very interesting because the affinity of that Novichok agent to the receptor was stronger than anyone had seen before. So I always thought, that from my understanding, you needed higher doses of the pralidoxime, but even then, like if it's not a strong enough of a competitive not agonist, but competitive, I guess, inhibitor, then certainly that would be troubling to treat. And before I forget, at some point I want to talk about when these toxidromes mix, but before that, let's get to anticholinergics, unless you had something to add.
No, that's that was a good discussion. Yeah, so the anticholinergic toxidrome is in some ways, right, it's the opposite of what we just said. It's really better described as the antimuscarinic toxidrome, because it's just those muscarinic acetylcholine receptors that are involved. But it causes dry skin and flushed skin. People will use the mnemonic hot as a hare, red as a beet, dry as a bone, mad as a hatter. One of my great teachers as a trainee, Lewis Nelson, would just call everything a pepper. So hot as a pepper, red as a pepper, dry as a pepper, blind as a pepper. Maybe peppers can't see, but that might be a better way to remember it. But with the anticholinergic toxidrome, you start with the pupils. The pupils are big. The skin is dry, the bowel sounds are decreased, and the mental status is agitated. The heart rate is fast, blood pressure is kind of normal to up, the respiratory may be a little fast, the temperature may be a little bit up. And so it can look similar to sympathomimetic toxicity, and we can talk about some of those differences later. But that's what you're going to see, this kind of flushed, agitated, tachycardic person.
Okay. What's like an example of that you would see?
Yeah. Probably the most common that we'll see in our world, in our environment, are people that overdose on, like, for example, like diphenhydramine, the active ingredient in Benadryl, also the active ingredient in Tylenol PM. Almost any over-the-counter sleep aid is diphenhydramine, so like Tylenol PM, etc., or some other anticholinergic.
Okay.
So, all these kind of first generation antihistamines like diphenhydramine are also anticholinergics, and they will cause that. And so, what happens? People either take a lot because they really want to go to sleep, not realizing that it's going to have these other effects. People might overdose on it. People might think it's harmless because they bought it over the counter. But then rarely, it'll be kids just trying to use it to get high. Because there are some anticholinergics like Jimson weed and other kind of herbals that people they'll want to hallucinate and see stuff with it. But personally, to me, it doesn't sound like a pleasant.
Yeah.
Sounds like an agitated, irritable high.
Yeah.
In fact, patients will be really irritable and they'll have these hallucinations of little people, call them Lilliputian hallucinations, like Gulliver's Travels.
Oh, wow. Yeah, that sounds kind of miserable.
No, it just sounds terrible.
Yeah. All right, so let's go to, just because we were talking about the parasympathetic nervous system and the anticholinergics kind of block that tone a lot. Let's talk about the sympathomimetics next, and we can talk about the sympathetic nervous system and how the upregulation occurs.
Yeah. So if you notice, with every toxidrome, I've been talking about a couple physical exam findings. So the mental status, the pupils, the bowel sounds, and the skin. And I've also been talking about vital signs. So that's how we organize our toxidromes and our tox physical exam. So for sympathomimetics, we talk about pupils being big, mental status being agitated, skin being sweaty. And the best place to check for sweaty skin is in that armpit. Check the axilla. And then bowel sounds are kind of like normal to increase with the sympathomimetic toxidrome. Vital signs, heart rate's fast, blood pressure's high, respiratory rate's fast, temperature is up. So these people are hot and they're agitated. And the sympathomimetic toxidrome is caused by things like cocaine, things like methamphetamine, all of your, bath salt type drugs, right? The cathinones. So these drugs all tend to put more norepinephrine and dopamine in that synapse. And when you do that, you're causing all the findings that I talked about.
Yeah, and going back to that MAP equation, well, there's a ton of things happening, right, that are increasing it. So we remember the MAP as a function of cardiac output, systemic vascular resistance. So not only do you have that increase in heart rate, you also have increased stroke volume, right? So certainly a bunch of things happening to increase that blood pressure. Do you have peripheral vasoconstriction with these two, or not so much?
Yeah. So you have peripheral vasoconstriction, and that can be really lethal because what happens is folks, like on a hot day, like you said, their hearts are beating hard with a lot of contractility. They're beating faster. But peripherally, there could be vasoconstriction from the adrenergic agonist effect. And we want vasodilation when we're hot because that helps bring blood to the surface and helps us cool down. But when you're vasoconstricted, you don't cool down. And so the way people generally die, if they're going to die from sympathomimetics, are complications of hyperthermia.
Mm-hmm. Okay. The what's always interesting to me is like, especially with cocaine, there's the localized effects, vasoconstrictive effects, right? Which eventually, if you see somebody that's used cocaine for decades, they won't have a nose, right? And it's kind of crazy. I've only
some septal,
yeah,
some septal injury,
yeah, just so much damage over time. And so, what are the treatments for these?
Yeah, so people die from sympathomedics from being agitated and hyperthermic. And so the treatment is to calm them and cool them, right? So how do we do that? There's no direct antidote. There's no naloxone that just like turns it off. So you really, it's like a multimodal approach, but generally benzos are our best friends. So we're giving benzos, like something like, I like stuff like midazolam, which is short acting but quick onset. And you're just, giving the patient midaz and trying to relax those muscles, relax that agitation, because that's what's making a lot of the hyperthermia is the muscular contraction and the agitation. If I'm checking a temperature, and if their temperature is under 103, I'm fine with that. I'm gonna give them enough sedatives that they can just relax without moving around too much. I don't want them to need restraints, physical restraints. I'd rather just sedate them, because with physical restraints, you're just making more heat. You're fighting the restraints. But if on the other hand, I find that your temperature is like 104, 105, you're up that high from a sympathometic, then I'm really nervous, and I'm really nervous about life-threatening hypothermia. And I want to correct that within 30 minutes. So if I see that, I'm going to be thinking about evaporative cooling or ice water immersion for you. And I'm going to even be thinking about intubation, paralyzing you to just shut your muscles down. Just shut them down so that you'll just stop having muscular contraction and just cool off.
Okay. So benzos, and we're going to obviously talk about a set of hypnotics here, but benzos, so we've talked about on the show before, glutamate kind of being the primary gas pedal of the central nervous system, and GABA being the primary brake pedal of the central nervous system.
Exactly, yeah.
Let's talk about why we're like, so first of all, I guess I should ask you, the benzos we're giving, are they working centrally, or are they working peripherally too?
They're working centrally, but that's mediating. But so does cocaine. Cocaine really is working centrally, and the effects of cocaine are mediated by the peripheral effects from the central effects of cocaine. And so benzos are working centrally.
Okay. Where does ketamine fit into this?
Cocaine has another effect that I didn't even mention.
Mm-hmm.
It's a topical local anesthetic, or it's a local anesthetic, and that works at the site. But that doesn't really come into play as a toxicity here.
I remember I don't have a memory of stocking this in the Pyxis, but I remember seeing this in a Pyxis in an OR this is now 10 years ago, when I was working as a pharmacy technician at Johns Hopkins Bayview. When we would stock the OR Pyxis, they had a couple Pyxises.
The ENTs might use it, or the ophthalmologist might use it.
Yeah. And I remember seeing that.
Numbing agent for eyes and nose.
Yeah. But that blew my mind. I was like, oh wow, I guess cocaine does have a medical use, huh?
A jar of cocaine.
Yeah. So where were we? So we talked about the benzos, how they assist with that. Where does ketamine fit into this for treatment?
So ketamine is a dissociative, and it doesn't. It's just like phencyclidine and PCP. They're both dissociative. And they didn't really fit into any of the toxidromes that I've mentioned.
Oh, sorry, I meant for treating, like, because in the pre-hospital setting we have, like, for at least in Maryland, I should tell you, because we have listeners from across the country and across the world, right? But for in Maryland, we call it severe agitation. We don't call it
we don't call it agitated delirium or excited.
Yeah, excited delirium anymore.
Yeah, it's severe.
But we can give ketamine for that. So how does the pharmacology of ketamine fit into the picture of what we're talking about?
So ketamine, it's a dissociative, and so in the perfect world, it will cause a it'll stop the physical behavior without causing a lot of respiratory depression. And patients generally don't have tolerance to it. It's not like benzos where the more alcohol you drink, the more tolerance you have to it. So ketamine tends to work, and it tends to work and tends to stop the behavior. It tends to be pretty effective. Now, there's got to be a downside, or else people would do it all the time. That'd be the only drug, right, if there wasn't a downside. And the problem with ketamine is you can get some laryngospasm, and that can be, really, really scary, because now, you've taken a patient who is stable and breathing, and now, you have an airway situation. And so it's not, the chances of it aren't zero. You can also have emergence reactions. So when the ketamine wears off, people can be more agitated. And so my take on it is if I'm in a situation where I just, no questions asked, the patient is at physical risk and I just need them stopped now, then ketamine's a good go-to. Like somebody who's used drugs and they're also a trauma patient and they're like bleeding everywhere and you just need to you can't just mess with benzos for the next 15 minutes titrating. You just need to shut them down.
Yeah.
On the other hand, people that are just a little agitated or moderately agitated, where I know I'm going to have some time, just give them a dose of benzos. If I need to give more, I'll give more. I like benzos because it's just very predictable and dose related, and I'm not going to get that laryngospasm.
Okay. Yeah, for us, again, in Maryland, it's a 100% consult drug unless there's immediate threat to life and limb of the patient or bystanders surrounding, us as clinicians. So,
yeah.
All right. So, let's go to, we've been talking about benzos. Let's talk about sedative hypnotics next.
Yeah. So sedative hypnotics, right? Probably, in some ways, probably the most common if we count alcohol. So alcohol, ethanol is a sedative hypnotic, but we might not always think about it like that, but it is. But the other common ones are the benzos. And there's dozens of benzos out in the world. In the U.S., we probably see the same, half dozen or so. So Ativan, aka lorazepam, diazepam, aka Valium, Librium, otherwise known as chloridized epoxide, midazolam, Versed, alprazolam, Xanax. There's others I haven't named. Famously, Rohypnol, flunitrazepam, I think, was famous for a minute as a sexual assault drug. Probably was never as widely used, but it was widely talked about. But all these drugs are GABA agonists, so they turn up GABA. And as you mentioned before, GABA is really the brakes of your nervous system. So by turning up the brakes, you cause sedation, you cause somnolence. There are also anticonvulsants, so you stop seizures. And all the benzos will do that, but they just will do it. They have different pharmacokinetics, so different onset, different durations of action. But they're all going to have that same final common mechanism. So if I see somebody with a sedative hypnotic toxidrome, I may not be able to tell whether they took alcohol or a benzo or a barbiturate, another sedative hypnotic, but I know how I'm going to manage it. And the way you manage sedative hypnotic toxidrome is just supporting and protecting the airway to the extent that you need to. So sometimes that just means sitting them up. Sometimes it means putting a nasal trumpet in. Sometimes it means intubating patients. So, but they're really, it's just supporting the airway. And there's a great historical anecdote with this. Have you ever heard of the term the Scandinavian method?
No, nope, I don't know.
Yeah. So back in the day, before the 40s and 50s, right? There was a common thinking in medicine that if you saw somebody in a coma, you needed to wake them up, right? So if somebody took an overdose of alcohol and they were sleeping, you needed to wake them up. Maybe give them some coffee and give them a cold shower and stimulate them, right? And that was just people even to the extent that they would give cocaine for barbiturate poisoning. They would give all kinds of pro-seizure medicines to barbiturate poisoning.
Oh, wow.
And this was the thing in modern medicine, or
Wow.
what they called modern medicine in the 40s, right, in the 50s. And this didn't really change until a fellow named Carl Clemmensen in Copenhagen, in Denmark, published a paper. I think the paper was called the Scandinavian Method, where they just took people that had overdosed on barbiturates, and they showed that if instead of trying to wake them up, they just supported their blood pressure with fluids, they supported their airway as needed, with ventilation, and they just left them alone, that they had really low mortality and people just got it. And that kind of approach is really like the centerpiece of modern medical toxicology, which is, let's not just focus on antidotes, let's focus on managing the patient. And so to this day, that's a focus for a set of hypnotics like benzo.
Yeah. Yeah, no, that's really interesting. The actually no, let's go into opioids next, and then we'll get into some of the weird stuff. So let's talk about opioids.
Yeah, so opioids, right, are super common, and we're in the midst of a massive opioid epidemic. So all of our clinicians, we're all just super familiar with this. But the opioid toxidrome, right? Small pupils, decreased mental status, sleepiness, decreased bowel sounds, cool skin. Blood pressure's kind of low, normal. Heart rate's low, normal. But these things they're not zero, right? Opioids are terrible medicines if you wanted to lower somebody's blood pressure. But the real key is the respiratory rate. And it's the thing that's special and dangerous about opioids is that they will titrate a respiratory rate to zero. And so people with opioid poisoning, they die from not breathing, right? They die from hypoventilation. They die from hypoxia, either one or both. And, I say the obvious, right? Because all our listeners know. But it's really worth saying it again and again, because if that's how you die, that's really the only feature that you need to worry about when you see it. So if you have a story about this guy overdosed on an opioid, he took all the fentanyl in the world, and you watch him, you come and you find him, and he's sleeping, but he's like breathing really well. Well, he doesn't need treatment. He doesn't need Naloxone right now. He's breathing well. Let's just get him to a place where we can watch him, get him to a hospital, and go from there. Right? And similarly, if you have a patient who presents with an opioid toxidrome, they're sleepy, they're decreased respiratory rate, and you have no history on them, or you have a history that they're the cleanest guy in the world and they never use any drugs. You know what? If you have a low respiratory rate, I'm giving you Naloxone. Right? Because I see the opioid toxidrome on your physical exam, and I'm going to give you Naloxone and see if I can get you breathing again. So again, we're treating the patient. We're treating the toxidrome. We're not treating like the rumor of a story. And if I don't see respiratory depression, then I'm not giving Naloxone. So that's how you die. And if you're not doing that, you're not going to die from it.
Okay. Now let's talk about so xylazine has been kind of like the hot topic, right? So and I remember it being an alpha agonist. I just Googled it. I was like, okay, good. It is an alpha 2 agonist. But like, how does that fit into the picture that we see? Because I'll tell you how we see it in the field. We give them naloxone, and their respiratory depression goes away, but everything else stays the same.
Yeah.
So how does that fit in, and what's the clinical management look like within the hospital?
Yeah. So xylazine, like you said, it's an alpha 2 agonist, which means it functionally works as a adrenergic antagonist. The way that works, it's so it causes bradycardia and hypotension. These drugs are also they're in the imidazoline family, and so they have some sedative effects that are similar to opioids. But like you said, they don't really cause a lot of respiratory depression. So what you're seeing is exactly what I'm seeing. Patients that are opioid and xylazine poisoned together tend to look like opioid poisoned patients, but maybe with a little more bradycardia and a little more hypotension. And then when you reverse the opioid, they still have some bradycardia and hypotension and sedation. Now, that's the bad part. The good part, the good message is that we're not finding these patients are dying any more than the opioid poisoners. And there are a few theories on why that is. It could just be that if you have fentanyl combined with xylazine, right? Some people call it trank on the street. You have fentanyl combined with xylazine. Then it takes less fentanyl to knock you out. So they take it, they're knocked out, but they took less fentanyl than the guy that took the full dose of fentanyl. Then you reverse the fentanyl, and now they're just somebody with xylazine. But the good thing is it doesn't seem to be more dangerous. Now it is on the other hand, it's worth pointing out, it's associated with some pretty nasty wounds. And so, that's perhaps less of an EMS problem, but more of like a chronic hospitalization problem.
Yeah.
People aren't entirely sure why xylazine may be associated with worse wounds than regular opioid. It might be because of local vasoconstriction. It might be some other.
Yeah, I was going to say like local tissue necrosis. Yeah, exactly. Yeah, I wonder if like that compound is like super, I don't know, like hypertonic or something. I don't know.
Yeah, could be something in there. Yeah, 100%. Maybe some hypertonic solution. Whoever's mixing it.
I mean, it's not exactly. They're not being made in like hoods and IV labs, so who knows?
Yeah. It's interesting that xylazine is approved for animal use. It's an animal tranquilizer, and as far as I know, it's not like a controlled substance, so it's not hard to get. It's not entirely clear why there's so much of it in drugs, because when you talk to patients, like people don't want it in their drugs. They say when you're using like your fentanyl, you want to feel hot. You don't want to like just fall asleep.
Yeah.
And, especially don't want to fall asleep and wake up in a hospital.
Yeah.
But so patients don't want it, but somebody's adding it to it, and on a pretty large scale, because it's seen all over the place.
Yeah, the human analog would be
Clonidine.
Yeah, Presidex, right?
Mm-hmm.
Is that? Yeah, it is Presidex. Yeah,
So dexmedetomidine,
exactly. Yeah.
Presidex or Clonidine are both in that same family.
Okay.
And those are FDA approved.
I do remember Clonidine being dispensed. Yeah. Some potential for abuse with Clonidine, correct?
Yeah, so Clonidine has some opioid-like effects, and so definitely, we've given Clonidine to people to treat symptoms of opioid withdrawal, and there are people that like to use Clonidine, recreationally, or they like the way it makes them feel.
Yeah.
But it's a blood pressure medicine, and it's a really potent blood pressure medicine, even though there's a big rebound hypertension associated with it. So I think most like cardiologists aren't in love with it.
Okay. I remember, dispensing Clonidine. I remember Tramadol not being controlled when I was a pharmacy technician. It went from not being controlled to controlled. I'm trying to think what else. Because I'll tell you, when I was right around 2014, I remember the amount of people coming in for fake scripts was huge, right? Because the paper scripts were big still. And I would oftentimes be the pharmacy technician working at like the drop-off station, and like people would try to convince me that these like misspelled, obviously very like too neat sometimes written prescriptions. I'm like, there's no way this is legit. Like, obviously this is stolen, All right, so we've kind of already talked about a lot of the major antidotes already that we talk about that we use in the pre-hospital setting. Let's go into a little bit. I'm just scrolling up in my notes here. So we talked about, for example, we talked about naloxone, obviously. So do you want to go into a bit of a mechanism discussion of how naloxone actually works at the molecular level, and then maybe go into bup and Suboxone and stuff?
Yeah, so naloxone is a mu opioid antagonist, and so there's three main types of opioid receptor. Really, the one that we really matters the most for all of us is the mu opioid receptor, because that's the one that mediates pain management. And it's also the one that mediates respiratory depression. So unfortunately, those two things are made by or modulated by the same receptor. Because if there was a drug that could cause pain management and euphoria without causing respiratory depression, that person who found that would be a billion. that would be a great find. But unfortunately, they're all on that mu opioid receptor, and naloxone is an antagonist of that. So the opioids will bind the mu receptor and activate it, and naloxone will bump them off and deactivate it. And naloxone has a lot of affinity for the opioid receptor, which means it bumps a lot of things off, including fentanyl, including fentanyl analogs. So naloxone is a great drug, and even in patients that took a lot of opioid X, naloxone tends to be effective. Sometimes you have to give a little more, but it's an effective drug.
Have you and I'm trying to look for the paper right now. Was it published in Resuscitation, the big naloxone paper that came out about God, I want to say it was either Open, JAMA, or do you know what paper I'm talking about?
I can't think of which one you're talking about.
Let's see here.
What was the gist of it?
Basically, folks that were given, and again, I'm going to butcher this because I don't have the paper in front of me, but basically, folks that were given naloxone and cardiac arrest had better ROSC outcomes.
Yeah, I've actually seen a paper like that. I think I saw one from Italy or something a long time ago. But because naloxone was this just overdose people or anybody?
I believe. Hold on. I'm going to actually find the paper because I'm going to. So
if you overdosed, then naloxone is it'll cause a lot of endogenous epi release, and so part of what you're seeing is just you're giving epi.
Okay.
You're giving naloxone, and we know that with epi you can get some nice transient, spikes in heart rate and blood pressure, and you can get ROSC. It's not always durable, but of course, if somebody is pulseless from an opioid overdose, you don't have much to lose. So
here it is. So it was it was JAMA Open. Yeah, Open JAMA. Naloxone and patient outcomes and out of hospital cardiac arrest in California by David G. Dillon et al. Was this original? Yeah, this was it. And what we'll do is we'll put the show in the show notes. I'll put a link to this. And let's see here. Let's run it through the abstract. Primary outcome was survival to hospital discharge. Secondary outcome was sustained ROSC. Covariates included patient cardiac arrest characteristics, non-shockable rhythm, any more comorbidity, unwitnessed arrest, and EMS agency. Cardiac arrest characteristics, e.g. age, sex, non-shockable rhythm, blah, blah, blah. And EMS clinician determination of out of hospital cardiac arrest cause as presumed drug related. So they cohorted patients that were presumed drug related. So that answered the one question or one comment you said. So in this retrospect, I'm just going to skip to the conclusion and relevance. In this retrospective cohort study, naloxone administration as part of EMS management of out-of-hospital cardiac arrest was associated with increased rates of ROSC and increased survival to hospital discharge when evaluated using propensity-matched or score-based models. Given the lack of clinical practice data on the efficacy of naloxone out-of-hospital cardiac arrest and or out-of-hospital cardiac arrest in general, these findings support further evaluation of naloxone, which is interesting because we've always been told, the paradigm has been, if they're in arrest, just work the arrest. Naloxone's not going to do anything. But if it, so maybe even in the, in these patients in particular, like you said, increase, endogenous epinephrine release, right? Which really isn't. Yeah, I guess that is what's happening. But I'd be very interested into whatever this research goes to next, because we don't give it, I don't think, in arrest. So at least in the pre-hospital setting.
Yeah, I mean, if you have a story of opioid overdose, and they're intubated and they're pulseless. So you've already fixed the airway. It's an interesting argument for that might be the only intubated patient where you'd say, yeah, let me try some Naloxone.
Yeah.
Because usually once they're intubated, there's never a reason to do it because you already fixed the breathing with intubation.
Yeah.
But in this one specific case, this type of case where they're pulseless, and you remember this paper, you might say, yeah, let's try to give Naloxone.
And hopefully in the pre-hospital setting, someone gave Naloxone before they intubated. Because I imagine you guys have already figured out in your differential, everything that would wake them up, you've already figured out before you tubed them in the hospital, I would hope.
Yeah, 100%. You find like an apneic patient.
Yeah. Unless it's like July 1st or something and it's a brand new guy or gal,
Yeah.
Then they get a demerit.
Yeah.
All right, so I want to talk about a couple more things. So specifically, let's go into bicarb a little bit, sodium bicarb and its mechanism for TCA overdose. And then I really want to go to glucagon. Let's talk about glucagon after that. So good.
Yeah. So sodium bicarbonate has been antidotal, or it's been used in cyclic antidepressant overdose, TCA overdose. And TCAs it's like a really vanishing overdose.
And these are the triptylines, right? Like amitriptyline, nortriptyline,
amitriptyline. Now, before the SSRIs were invented, so like Paxil and Prozac, like paroxetine and fluoxetine, before those were invented, the TCAs were the kind of the most commonly prescribed antidepressants. And so there did used to be a lot of overdoses with them. They're so commonly prescribed, and you're prescribing a drug to people with depression, you're going to get some suicidal attempts. And there was a pretty scary toxidrome associated with that, where people would be, hypotensive and tachycardic. But there was a classic EKG finding of this widened QRS, and it's been observed that when you give sodium bicarb, the QRS would narrow, it would become a normalized EKG. And that was not just a way of treating it, but it was also a way of diagnosing it. And the simplest way to think about it is that these cyclic antidepressants work as sodium channel blockers in the heart. And so when you're giving sodium bicarbonate, you're giving a big sodium load, because sodium bicarbonate is 9% sodium. So it's pretty concentrated sodium solution, as opposed to what we call normal saline is 0.9%.
Mm-hmm.
So it's a pretty concentrated salt solution. So you're putting a lot of sodium in there, and you're really overcoming that blockade of the sodium channel by the TCA.
And I mean, because so when you say block there's TCAs block, say, I guess, voltage gated sodium channels.
Yeah, these and really, particularly phase 0, we call phase 0 depolarization. On the EKG, that's like that first deflection, that really steep fire.
Yeah.
And TCAs block that.
Okay. So then you're really just, so by sheer will of a lot of salt, you're trying to overcome that blockade. Okay, interesting. I didn't know that. Wow. Okay.
Yeah.
I always wondered how that worked. Interesting. So it's not a primary acidosis fixer. You're trying to stabilize the myocardium. It's
not working, no.
Okay.
But by alkalinizing, I think you are decreasing the affinity of the drug for the receptor.
Okay.
So there is the alkalosis does help.
Okay. But it's a secondary effect
to sodium load is the primary effect. Although there's some, people have argued both ways. But we know that you can give other bases and they won't work as well. But you can also give 3% saline, sodium chloride, without the bicarb, and that also won't work.
Interesting.
It's probably a combination, but I think the sodium load is more important.
Yeah, the bicarb side. Oh, interesting. Yeah, once it disassociates. Interesting. Wow. Yeah. I'm learning a lot here. Cool. Let's talk about glucagon and beta blocker overdose. Well, I guess let's talk about beta blocker overdose first, and then we'll talk about glucagon, because I think this is a very interesting mechanism.
Yeah, so beta blockers will cause bradycardia, and hypotension. Those are the two dangerous.
And these are drugs that are Olol, Alol. We know, metoprolol is a common one, but also like atenolol, propranolol is like a lot of mental health indications, right? For propranolol.
Yeah, all the LOLs. Yeah,
Mm.
propranolol, atenolol, metoprolol.
Mm.
And propranolol has a few other indications where it's used for like stage fright and performance anxiety, and has some, so some of that. But yeah, all these drugs, they end in Olol.
Yeah.
And so glucagon will essentially bypass the beta receptor and will kind of activate the downstream effects of the beta receptor. So if you can picture that.
Yeah.
And so with beta receptors, they end up modulating calcium entry into the cell. And so what happens in these cells, what's supposed to happen is the beta receptor is activated, and then that beta receptor in turn opens up calcium channels, so calcium rushes into the cell, and that then turns on intracellular calcium-mediated calcium release. So through the sarcoplasmic reticulum, calcium rushes in and makes the muscle, the heart muscle or the blood vessel, wherever you are, makes that contract.
Yeah.
So beta blockers, you block that beta receptor and you can't get those downstream receptors. And so what glucagon does, it takes the next step after the beta blocker. I believe it's something called cyclic AMP, and it turns that up.
Yeah.
And you get more. So you get more. That will replace the beta, and you'll get more. So even though the beta receptor is blocked, you'll still now get all the downstream effects, like calcium-mediated calcium.
Yeah, the way I teach GPCRs or G coupled protein receptors, G protein coupled receptors. Sorry, it's late. I always, so for listeners that may not be familiar with what we're talking about right now, think of when you walk into a room. If you imagine there's a room that you have a light switch on the outside of the room, right? That light switch kind of has an effect that happens inside of that room, right? The light turns on inside the room. So that's how I consider a G protein coupled receptor. Just don't get bogged down in the details. Just think of it as a switch on outside of a cell, right? So if you have like a heart cell, a beta receptor, I just think of it as a beta 1 receptor. Beta 2 would be obviously in the smooth muscle of the lungs. I just think of it as a light switch that causes something to happen on the inside of the cell. You also have receptors on the inside of the cells. We don't have to talk about that today. But what's happening with beta blockers is you're blocking the light switch from being turned on. So what glucagon does, and to be clear, this is not given intramuscularly like we would give for low blood sugar. It's given intravenously and in way higher doses. Oftentimes every 5 minutes you have to keep up the effect that you need. This utilizes another pathway, like Dr. Stolbach said, and we're getting the same net result, which is the increase in cyclic AMP, right? Which then, yes, induces the calcium-induced calcium release, which is very crucial for that actual heartbeat to occur or that constriction to occur. The same reason that we give calcium for a severely hyperkalemic patient, right? We're trying to induce, that cardiac contractility, but also increase that SA node firing to try to get your heart rate back up. This mechanism, when I learned about it, was so interesting to me. I was like, well, who would have thought that that's how it works? But really, we're taking advantage of our body's own physiology, which is super interesting. Anything to add on that, on glucagon?
No, that's a great explanation. I never heard about that light switch analogy, but I like that.
So I don't know, but I would hate to take credit for something, but I'm pretty sure I came up with that. Like,
nice.
Because I'm always trying to find a way to teach complex physiology, because my bachelor's is in physiology. I try to teach, when I'm teaching my paramedic students, I try to figure out a way to dumb ideas down, but to say not dumb ideas down. I shouldn't have said that. Make complex topics more palatable, right? But at the same time, I realize that I know enough just to be dangerous, right? I'm certainly not an expert in this, so I try to like limit my analogies. But
Good. I think there's no shame in. We're always dumbing things down.
Yeah,
that's how we all have to understand these things.
Yeah,
Be included.
Fair enough. Let's see here. So, yeah, we went through the major antidotes that we utilized. Let me just I'm scrolling back up to my notes. Let's see here. I guess we didn't talk about like cyanide, and but that's okay. Anything else you want to cover? Anything else that I should be asking you that I haven't asked you?
No, it's a good discussion. I think just overall, kind of the take-home message that I like to give is that when we treat poisoning, we really take the approach, treat the patient, not the poison.
Mm-hmm.
And so we really, with toxidromes, we look at the final common mechanism of how somebody might die, and we just try to get in the way of that. So with some of our toxidromes, like the opioid toxidrome and the sedative-hypnotic toxidrome, they kill you by sedation and respiratory depression. So if the drug might kill you by respiratory depression, my antidote is to get you breathing again, whether it's Naloxone, whether it's positioning you, whether it's a bag, but I'm going to get you breathing again. On the other side of the spectrum, you got your anticholinergics and your sympathomimetics, right? Your alcohol withdrawal, and that makes you hot and agitated. So all those kill you from complication of hyperthermia. So what am I going to focus on? I'm going to focus on calming you and cooling. So, at the end of the day, there's a lot of drugs in the world, more than we can count. But there's really only a few common pathways that result in most of the badness. And if you just kind of work on treating the patient, again, not the poison, and focusing on, they're not breathing, get them breathing. If they're really agitated, calm them and cool them. That's 90% of it. Don't get too bogged down in like what they take, how much they take, when did they take it, and just focus on those aspects, supporting the patient. Have good results, and you'll take care of a lot.
Yeah, no, I certainly appreciate that. When I teach my students, what I tell them is, your body has a set point, right? For any physiological parameter, it has a set point that it wants to be at. And the reason I say that is because when you think about what actually performs our life functions, right? It's proteins, right? Proteins are the things that actually do life, all the things in our bodies. And I always make the joke that the proteins have a very strong union, and the union has negotiated very strict working parameters, right? Set pH levels and temperature and so on and so forth. And any medication we give, or any toxin or poison that our patient is exposed to, is fudging with some sort of physiological parameter, because either that set point was moved away from where it's supposed to be, or that physiological parameter was moved farther from where it was supposed to be. And we're trying to get it to a steady state to be able to maintain that homeostasis and get our body back into some functioning order. And that's really what those, for today's topic, why we give antidotes, or if we have someone that's, severely symptomatic with a tachycardia, why we light them up, because we're trying to get them back to that set point and fix the pathology that's causing their issues. I think this was a really cool conversation. I think it's the start of hopefully a lot more conversations. You were an awesome guest. Did you have any closing comments?
No, I think I said everything I want to say. Thank you so much for having me. This has been a lot of fun.
Yeah, thanks for coming on. Really excited to have you on. We for some of our listeners, I've mentioned jiu-jitsu before. That's how I met Dr. Stolbach. He's at the same gym that I go to, and we plan on talking about hopefully at least a couple more topics. So, Dr. Stolbach, thank you so much for coming on the show. for the listeners. As always, I really appreciate everyone tuning in, listening, giving comments, feedback, participating in our social media. I'm not exactly sure when this episode is going to publish, but by then, if it's not clear with our social media, it'll be clear that we've launched our website finally. We had a website for a couple years. I decided to bring it, take it down and then bring it up, kind of updated. So we have an alertmedic1.com. So please take a look at that. We'll have an email list soon. Follow us on Instagram. Josh and the team are doing a fantastic job with our social media. Follow us on Spotify. That helps us out a ton. And give us a review. Give us an honest review. If there's something that we can do better, please let us know. But yeah, that's all we got for now. Thanks for listening. That's it for now. Have a good night. Or day, I guess I should say.